presentation is about non-motor symptoms in Parkinson's disease, clinical aspects, and management. I have no disclosures. The objectives are to describe the spectrum of non-motor symptoms in Parkinson's disease, to review their clinical aspects, and to summarize the current management strategies for these symptoms. Non-motor symptoms are prominent and disabling manifestations of Parkinson's disease and develop throughout the course of PD from the premotor to the late stages. Over time, these non-motor symptoms accumulate and eventually become a major determinant of quality of life. The management of non-motor symptoms remains suboptimal with only a few level 1 evidence-based therapeutic recommendations. Non-motor symptoms can be approached from different perspectives. For example, early versus late, some non-motor symptoms are prone to occur in the early stages of Parkinson's disease, like hyposmia, REM sleep behavior disorder, constipation, depression. And in the last years, a number of other non-motor symptoms have been recognized to be present by the time of PD diagnosis, like anxiety, pain, orthostatic hypotension, erectile dysfunction, excessive daytime sleepiness, and executive dysfunction. Some of these early manifestations may precede the onset of motor symptoms by years or decades, and their presence has led to the concept of prodromal Parkinson's disease, which is a stage of PD in which there are signs and symptoms of neurodegeneration, but are insufficient to define a clinical diagnosis of Parkinson's disease. And there is a lot of research that has been done in this field of prodromal Parkinson's disease in order to address which cases presenting one or more premotor manifestation will actually develop Parkinson's disease, and more importantly, when. And that will be very important if neuroprotective agents become available for clinical trials in the prodromal stage of Parkinson's disease. On the other hand, we have late non-motor symptoms that tend to occur in the late stages, like dementia, psychosis, dysphagia, and weight loss, among others. Fluctuating versus static is another way to approach non-motor symptoms. There is a subset of non-motor symptoms that fluctuate in coincidence with motor fluctuations and are referred to as non-motor fluctuations. These fluctuating manifestations occur in the off-motor state in 82% of cases. And their recognition is very important because it has therapeutic implications. Typical of related non-motor symptoms are anxiety, slowness of thinking, pain, urinary urgency, drenching sweat, tachycardia, and hypertension. Rarely, these manifestations may occur in the on-motor state, and conversely, euphoria, high motivation, and hyperactivity, when occur, are only present in the on-motor state. The effect of dopaminergic treatment on non-motor symptoms is variable. Some can be improved, like depression, anxiety, fatigue, apathy, or pain. Others can be aggravated, like hallucinations, psychosis, dementia, excessive daytime sleepiness, orthostatic hypotension, and constipation. And there is a small group that can be triggered or caused by dopaminergic drugs, like obsessive compulsive disorder, panding, and dopamine dysregulation syndrome. The spectrum of non-motor symptoms comprise a wide range of manifestations that are classified into 4 groups: autonomic, sleep, neuropsychiatric, and sensory problems, and a few manifestations that are more difficult to classify. I will describe the most frequent non-motor symptoms within each of these categories. So let's start with dysautonomic dysfunction, like gastrointestinal symptoms, which are prominent symptoms of Parkinson's disease. Drooling, dysphagia, gastroparesis, and constipation are among the most frequent GI problems. Drooling is the excessive accumulation of saliva in the mouth, usually flowing outside the oral cavity. And in Parkinson's disease, drooling is a consequence of impaired clearance of saliva due to oropharyngeal dysphagia and low frequency of swallowing. And that's why drooling is not an actual dysautonomic manifestation. In fact, salivary secretion in Parkinson's disease is reduced, and what PD patients have is hyposialuria. In the management of drooling, injections of botulinum toxin A or B in parothis or submandibular glands are considered efficacious and clinically useful. Glycopyrrolate, a muscarinic antagonist, is considered possibly useful, but for a short-term treatment. Gastroparesis, defined as delayed gastric emptying on scintigraphy, together with symptoms like early satiety, fullness sensation, abdominal distension, bloating, nausea, and vomiting, all manifestations that reflect GI tract hypomotility due to dorsal motor nucleus of the vagus and involvement or the enteric nervous system, as both are affected by Lewy pathology. In the management of delayed gastric emptying, recommendations like taking small frequent meals can be helpful. The use of domperidone, which is a D2 receptor antagonist, mostly in the upper GI tract. And importantly, domperidone at doses of 10 milligrams TID does not cross the blood-brain barrier, so it does not worsen Parkinsonism. There are other agents, other prokinetic agents like 5-HT4 receptor antagonists like mosapride or prucalopride, but there is insufficient evidence about their efficacy in the PD population. Constipation is one of the most common and distressing GI symptoms in Parkinson's disease, may precede the onset of motor symptoms by decades. The prevalence depends on the criteria employed. By using the wrong criteria, which requires at least 2 of less than 3 bowel movements per week, sense of incomplete evacuation, straining, hair stools, the prevalence found was 59% among PD cases, which was significantly higher compared to controls using the same criteria. There are 2 types of constipation in Parkinson's disease: slow transit constipation related to less frequent bowel movements due to slow colonic transit, and outlet constipation, which is difficulty with the act of defecation itself. Dysenergic defecation occurs in 60% of PD cases, and it is characterized by paradoxical contraction of the puborectalis muscle and the external anal sphincter, and has been proposed that this could represent focal dystonia. In the management of slow transit constipation, recommendations like increasing fluid and fiber intake, daily exercise are helpful. The use of probiotics and prebiotic fiber has demonstrated in randomized clinical trials that is efficacious and clinically useful to treat PD-related constipation. Other therapeutic options are osmotic laxatives like macrobol or lubiprostone, which is a chloride channel activator that increases intestinal fluid secretion. To treat outlet constipation, biofeedback therapy training may improve the synergia of the abdominal and anal sphincter muscles. Botulinum toxin injected in the puborectalis muscle may improve paradoxical contraction. Urologic manifestations occur in 40% of PD cases, and the most common problems are nocturia, increased frequency, urinary urgency, and urge incontinence. Nocturia is defined as waking 1 or more times to urinate at night, with each episode preceded and followed by sleep. It occurs in up to 60% of PD cases, may result in poor quality of sleep, and it is associated with an increased risk of falls, hip fracture, and mortality. In PD, nocturia is usually related to detrusor overactivity and reduced bladder capacity. In some cases, the underlying mechanism may be nocturnal polyuria, which is an increased production of nocturnal urine, usually related to a number of medical conditions. In some PD cases, both detrusor overactivity and nocturnal polyuria may occur simultaneously. In the management of nocturia, the first important thing is to rule out a urinary tract infection, prostate disease in men, and pelvic floor disease in women. Some behavioral interventions like minimizing fluid intake before sleep are helpful. To treat detrusor overactivity, drugs like sulfenazine, an antimuscarinic agent, and mirabegron, a beta-3 adrenoreceptor agonist, can be useful. In some cases, the use of botulinum toxin injections in the detrusor muscle can alleviate nocturia. To treat a nocturnal polyuria, the most important thing is to evaluate and treat the underlying medical condition. And in some cases, the use of desmopressin can be considered. Orthostatic hypotension is defined as a fall of 20 or 10 millimeters of mercury in systolic or diastolic blood pressure, respectively, within 3 minutes of standing. In Parkinson's disease, orthostatic hypotension is usually asymptomatic, tends to occur in older cases and at later stages of PD. There is a minority of PD cases that present with early and prominent orthostatic hypotension, sometimes before initiating dopaminergic treatment. Typical clinical manifestations of orthostatic hypotension are lightheadedness, dizziness, syncope, blurred vision, and coat hanger headache upon standing. Some PD cases with orthostatic hypotension may also experience supine nocturnal hypertension and postprandial hypotension. The mechanisms of orthostatic hypotension in PD are baroreflex impairment with impaired sympathetic vasoconstriction in response to orthostatic stress and the loss of sympathetic innervation of the heart. The management of orthostatic hypotension, as with many other non-motor symptoms, start by reducing or removing medications that could be aggravating, in this case, orthostatic hypotension. Patients should be educated about standing up slowly, the use of support stockings, sleep with the head of the bed elevated, avoid precipitating factors like alcohol, and practice regular exercise. Hydration is an important issue in the treatment of orthostatic hypotension. A daily intake of 2 or 2.5 liters of water and 10 to 20 grams of sodium is recommended. Adjustments in diet are particularly useful in cases that present postprandial hypotension and comprise recommendations like taking small frequent meals, reduce carbohydrates, and take caffeine after meals. If pharmacological treatment is needed, in some cases, domperidone can improve orthostatic hypotension. Other ways, fludrocortisone is commonly used. It produces volume expansion. Then there are drugs that promote vasoconstriction, like midodrine and droxidopa, which are sympathomimetics. And there's also pyridostigmine. In some cases, to prevent vasodilation, the use of NSAIDs and octreotide can be indicated. Let's talk about sleep disorders. Sleep disorders may occur during daytime, like excessive daytime sleepiness, or nighttime, like insomnia, REM sleep behavior disorder, restless leg syndrome, periodic limb movements, sleep disordered breathing, and circadian rhythm disorders. RVD is a parasomnia characterized by repeated episodes of REM sleep-related vocalizations and/or complex motor behaviors. It is the strongest prodromal marker of synucleinopathies, including Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. RVD may precede Parkinsonism or dementia by years or decades. And unlike other prodromal symptoms of Parkinson's disease, idiopathic RVD is highly specific for synucleinopathies, and more than 90% of polysonogram-proven idiopathic RVD cases will develop a synucleinopathy. A diagnosis of definitive RVD requires criteria that must be met and requires a polysomnography. The core objective finding in the polysomnography is REM sleep without muscle atonia, which is necessary for RVD diagnosis, together with abnormal behaviors during REM sleep documented by video polysomnography, or a typical history of dream enactment behaviors, and always that the disturbance is not better explained by another condition. In Parkinson's disease, the prevalence of polysonogram-proven RVD is approximately 50%. Enactment behaviors in RVD are highly variable across patients and across nights, and usually start more than 2 hours after sleep onset and predominate in the second part of the night. Dreams content is often violent, with the patient being attacked or chased, and a sleep-related injury to the patient or bed partner occurs in 32% and 64% of cases, respectively. The management of RVD comprises a review of patients' medication regimen in order to reduce or discontinue drugs that could be precipitating or worsening RVD, like SSRIs, tricyclic antidepressants, or antipsychotics. An education of patient and bed partner is very important, and also an evaluation of sleep and environmental safety in order to minimize the risk of injury. If pharmacological treatment is needed, clonazepam and melatonin are the most widely used agents. And interestingly, the data available on the efficacy of these agents is in the PD population with RVD is poor, and the results are controversial. Insomnia is a difficulty in initiating sleep, maintaining sleep, or waking earlier than desired. Most PD patients have problems with maintaining sleep and present sleep fragmentation, which occurs in 80% of PD cases. The etiology of sleep fragmentation is related to overnight emergence of either motor symptoms like tremor, dystonia, restlessness, akinesia, or non-motor symptoms like nocturia, other concomitant sleep disorders, hallucinations, nightmares, anxiety, or depression. In addition to these factors, a neurodegeneration of sleep regulatory centers, like the locus coeruleus, subcoeruleus, or the pedunculopontine nucleus, would also play a role. In the management of sleep fragmentation, the first step is try to identify which are the factors that are awake in PD patients. If these are motor symptoms, the strategy indicated is to optimize dopaminergic therapy. If the underlying problem is anxiety or depression, cognitive behavioral therapy or antidepressants are indicated, together with behavioral approaches like adequate exposure, exercise training programs, and restriction of daytime napping. If there are other sleep disorders, will have to be treated for RVD, clonazepam, and melatonin. For restless leg syndromes, gabapentin, pregabalin, or dopamine agonist. And if there are sleep apneas, continuous positive airway pressure is useful. In some cases, the use of esopiclone or melatonin can be necessary. These drugs are considered possibly useful in the management of insomnia in PD. Excessive daytime sleepiness, or EDS, is the inability to maintain wakefulness and alertness during most working periods of the day. Sleep attacks may occur in patients with EDS, and there are episodes of unexpected sudden onset of sleep, and they are part of the spectrum of EDS, but their presence is not mandatory. EDS may have safety implications, particularly in PD patients who drive, and also because lack of awareness of this problem is very common. EDS may result from poor quality of sleep, be a side effect of a medication, and also may be related to PD intrinsic mechanisms as a loss of hypocretin has been found in pathological studies in PD cases. In the management of EDS, it is very important to address quality of sleep and identify if there is a nighttime sleep disorder and treat it. And also a review of patients' medications in order to rule out a possible side effect of drugs. Non-pharmacological approach includes adequate light exposure and physical activity. If pharmacological treatment is needed, modafinil is considered possibly useful for the treatment of excessive daytime sleepiness in Parkinson's disease. Let's move on to neuropsychiatric symptoms like depression. Depression may occur across all stages of Parkinson's disease and affects up to 40% of PD cases. In general, PD depression is mild, and it is frequently associated with anxiety, apathy, and anhedonia. Anxiety may present as generalized anxiety, panic attacks, or social phobia. Apathy can be difficult to separate from depression itself, but what distinguishes apathy is a profound indifference and reduced interest. Anhedonia is characterized by the inability to experience pleasure. In Parkinson's disease, depression has been associated with dysfunction of dopaminergic, serotoninergic, and noradrenergic pathways in the limbic system, and also with the loss of cortical cholinergic neurons. In the management of depression and anxiety in PD, it is very important to determine whether these manifestations are not related phenomenon. If they are, the strategy indicated is adjustment of anti-Parkinsonian medication. If they are not, and depression is mild, the treatment of choice are non-pharmacological interventions like cognitive behavioral therapy, psychotherapy, or repetitive transcranial magnetic stimulation. All of these treatments are considered possibly useful with insufficient evidence. If pharmacological treatment is needed, the only two compounds that have demonstrated in randomized clinical trials to be efficacious and clinically useful are pramipexole and venlafaxine. Now, interestingly, for SSRIs, which are commonly used to treat PD-related depression, there is insufficient evidence about its efficacy, and so far they are recommended as possibly useful. And the same occurs with tricyclic antidepressants. Psychosis in Parkinson's disease occurs usually late in the course of the disease. The most common psychotic manifestations are visual hallucinations, which occur in 40% of PD cases. Psychosis in Parkinson's disease comprises a spectrum that starts with illusions, minor hallucinations like presence or passage phenomenon, then well-structured hallucinations, and finally delusions. PD psychosis is the strongest predictor of nursing home placement in PD cases, and it is associated with a higher mortality. The underlying mechanisms of visual hallucinations are unclear. PD medication can precipitate visual hallucinations. However, it is now accepted that visual hallucinations could not be a mere side effect of dopaminergic drugs, and a number of factors have been implicated in their pathophysiology. For example, impaired visual input through ophthalmic factors, abnormal cortical vision processing, morphological changes in the retina, and decrease in retinal dopamine concentration. In the treatment of a psychotic event in Parkinson's disease, it is very important to rule out an underlying medical condition, usually an infection, and also a pharmacological trigger. Reduction of dopaminergic medication is usually necessary, starting with anticholinergic, followed by amantadine, racetyline, dopamine agonist, and in the last place, levodopa. If antipsychotics are needed, quetiapine, clozapine, and pimavanserin can be used. Quetiapine is commonly used, however, there is insufficient evidence about its efficacy as an antipsychotic. Clozapine and pimavanserin have demonstrated to be efficacious and clinically useful in randomized clinical trials. And with clozapine, there is a risk of agranulocytosis, so that requires monitoring. Cognitive dysfunction in PD may present with different cognitive syndromes. Mild cognitive impairment is a cognitive decline that is not normal for age, but with essentially normal functional activities. It occurs in 27% of PD cases, and it increases the risk for the development of dementia. And in some cases, mild cognitive impairment may occur in the early stages of PD. And in those early cases, the main feature is an executive dysfunction syndrome. PD dementia, or PDD, is characterized by impairment in at least two cognitive domains, and these deficits have to be severe enough to impair daily life. The point prevalence of PDD is approximately 31.5%, and the cumulative prevalence is 75 or 80% after 10 or 20 years, respectively. The distinction between PDD and dementia with Lewy bodies may be challenging because there is clinical and pathological overlap. According to the one-year rule, a diagnosis of PDD was made when dementia developed at least 1 year after the onset of motor symptoms. Now, the new clinical diagnostic criteria for Parkinson's disease propose that PD can be diagnosed regardless of when dementia occurs in relation to Parkinsonism onset. The management of cognitive dysfunction in PD and PD dementia relies on the use of acetylcholinesterase inhibitors. Rivastigmine has demonstrated to be efficacious and clinically useful in clinical trials. Now, in clinical practice, it has to be said that the benefit that can be achieved with this compound is modest. and the same occurs with donepezil, galantamine, and memantine. Now let's talk about sensory symptoms like olfactory dysfunction. Hyposmia is present in 90% of PD cases by the time of diagnosis, and olfactory loss is a premotor marker of Parkinson's disease. In general, hyposmia in PD is bilateral, is not related to disease duration or severity. Olfactory dysfunction is usually stable over time once a diagnosis of Parkinson's disease has been established, and anti-Parkinsonian medications have no influence on the olfactory dysfunction. The underlying substrates of hyposmia are not clearly established, but it is believed that the compromise of the olfactory bulb is probably implicated in the dysfunction. Hyposmia increases the risk of developing Parkinson's disease, and in longitudinal studies, it has been shown that the combination of hyposmia with an abnormal DET scan of the striatum can identify individuals at high risk of Parkinson's disease. And among those hyposmic individuals, a higher reduction in the dopamine transporter binding is associated with a higher risk of developing Parkinson's disease in a relatively short period of time. There are no evidence-based recommendations for the management of olfactory dysfunction. A small study has shown that olfactory training was useful to improve the ability to identify olfactory stimuli, and subthalamic deep brain stimulation has been associated with improvement in odor discrimination, identification, and/or thresholds in a few reports. Now let's talk about pain, which is a very common non-motor symptom in Parkinson's disease. There are different kinds of pain. The most common pain is musculoskeletal pain, which usually is localized around joints. It is related to rigidity and skeletal deformities. A typical presentation of musculoskeletal pain is like a frozen shoulder preceding a diagnosis of Parkinson's disease. Dystonic pain or painful dystonia may present as early morning dystonia, off dystonia, peak dose, or biphasic dystonia. Radicular or neuropathic pain is described as the sensation of needles or pins localized in a root or nerve territory. Central or primary pain is a neuropathic sensation poorly localized and sometimes related to an internal organ and referred to as visceral pain. For akathisia, it's not an actual pain, but a discomfort, which is described as a sense of generalized inner restlessness and the urge to move, very similar to what occurs in restless leg syndrome, but not confined to the legs. In Parkinson's disease, more than one kind of pain may occur simultaneously. In the treatment of pain, but the first issue that has to be addressed is whether pain is a fluctuation-related pain. And in that case, adjustment of anti-Parkinsonian medication is usually useful. If the dystonic pain is not alleviated after dopaminergic drugs, other therapeutic options are the use of botulinum toxin injections for focal dystonia, or anticholinergics, baclofen, and in some cases, deep brain stimulation of the STN or the GPI could be considered. To treat chronic and severe pain, the combination of oxycodone and naloxone has been shown to be possibly useful, and transdermal rotigotine has also been studied for chronic pain in PD, but so far the results are insufficient. I will finish with a few conclusions. Prodromal Parkinson's disease provides an opportunity for future therapeutic interventions aimed at delaying PD progression. Among premotor manifestations, RVD is the only one that has high specificity for a synucleinopathy. Non-motor symptoms can be precipitated or worsened by drugs. Therefore, a review of patients' medications is always necessary. And finally, the recognition of fluctuation-related non-motor symptoms is important because they can be improved by adjusting dopaminergic therapy. Thank you very much.
Thank you for joining